She will.
Yeah. So, can you see the slide?
Yeah, the first
Okay.
slide is very visible to me.
Okay.
A very good evening and greetings to everyone present here. Being Medic presents to you a workshop, Wrestle High Blood Glucose Levels, on the occasion of World Diabetes Day. World Diabetes Day was created in 1991 by IDF and World Health Organization in response to growing concerns about the escalating health threat posed by diabetes. Every year, the World Diabetes Day campaign focuses on a dedicated theme that runs for one or more years. The theme for World Diabetes Day 2020 is the nurse and diabetes. Our guest speaker for the day is Dr. Sashti Narayan Chakrabarti, sir. So we are glad to have you today with us. He is MBBS MD Community Medicine, Fellow of Diabetes India, PG Diploma Cardiology and PG Diploma Clinical Endocrinology and Diabetes RCP UK, Chief Consultant Department of Diabetes, Thyroid and Preventive Medicine at Annapurna Health Point Hospital, Rajband, Durgapur. He has also been ex-associate professor and ex-consultant at Integrated Diabetes Clinic, IQ City Medical College and Hospital. You may post your questions in the live chat down below and it will be answered at the end of the session. And we'll also provide you with the feedback form at the end of the session. So over to you.
Thank you. So, very good evening to all of my students and all the attendees present here. Today, we all together to observe, you can say, celebrate World Diabetes Day that is supposed to be celebrated on 14th November, but somehow 14th November is, one kind of festive season observed in our country, and many of us will observe Diwali, and many of us will observe Kali Puja on that particular day. So that's why the observation of World Diabetes Day is considered today, 12th November. So it's a very important topic, World Diabetes Day. Next slide, please. World Diabetes Day. The first thing I'll speak about World Diabetes Day is speaking about Dr. Frederick Banting. Without a remembrance of his name, I'm pretty sure that celebration or observation of World Diabetes Day is nothing, because he is the man. Please change the slide. Because he is the man of discovery of insulin. He, along with Best, is also a scientist, is a colleague of him. Uh, Both discovered insulin, and
Hello. Hello.
Hello.
Yes, sir, you may continue.
Oh,
Oh,
okay. Sorry for the technical issues. Okay, there is a peculiar sound here. Okay, I guess it's not.
so
So
here
here
in
in
the
the
slide,
slide you can see
the
the
very
very
famous
famous
Dr.
Dr.
Frederick
painting,
and
and
his
his
birthday
birthday
is
is
in
in
November,
November,
and
and
that's
that's
why
why
the
the
World
World
Diabetes
Diabetes
Day
Day
usually
usually
celebrated.
celebrated.
So
So
before I
before I
speak
speak
any
any,
word, I would
I'd
like
like
to
to
convey
convey
my
my
regards
regards
and
and
respect
respect
to
to
this
this
great
great
person,
person,
because
because
after
after
discovery of
discovery,
insulin, the
the
entire pathophysiology, concept, treatment
treatment
guideline,
guideline
everything changed drastically.
drastically.
Particularly, it
Particularly,
was like a
a
gift
gift
from
from
God's
God's
side
side
for
for
the
the
type
type
1
1
diabetes
diabetes
patient.
patient.
Yeah. Okay,
Okay,
next
next
slide,
slide,
please.
please.
That
That
symbol
symbol
you
you
usually
usually
see
see
everywhere,
everywhere.
that
That
blue
blue
circle.
circle.
It
It
is
is
a
a
symbol
symbol
of
of
unity
unity
against
against
diabetes.
diabetes.
Uh,
Uh,
this is
this
a
is a
positive
positive
symbol
symbol
across
across
culture.
culture.
The
The
circle
circle
symbolizes
symbolizes
life
life
and
and
health.
health.
Is
Is
my
my
word is
word is
echoing?
echoing?
Is my
Is my
speech is
speech is
echoing?
echoing?
So your voice is echoing. So can you please mute yourself and then unmute once?
Okay.
Okay.
Yes, it's better now.
Okay.
Okay.
So
So
why
why
blue?
blue?
The
The
color
color
blue
blue.
reflects. No, I
No,
am
I'm
logging
logging
out
out
and
and
will
will
come
come
back
back
because
because
it's
it's
echoing.
echoing.
Just
Just
bear with me.
one few. বুবু আমি কথা বললাম করলাম
Hello.
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 Yes, sir.
Is everything fine?
Yes, it's better now.
Okay, thank God. So, should we start from the very first slide, or I should
So we
continue from?
so we can start from the first slide.
Okay, okay. So, bye bye. Thank you.
Yes, sir.
So, once again, good evening, all my students and all the attendees here. We all together are observing the World Diabetes Day that is usually celebrated on 14th November. But due to festive season, Diwali is 14th November, as well as many of us will be celebrating Kali Puja on that particular day. So that's why its program has been changed. And today we'll enlighten us about different aspects of diabetes so that our future prospect will be very helpful. We'll be able to tackle each and every patient of diabetes in our day-to-day practice. Uh, you know, Before I proceed for the particular topic regarding diabetes, I will convey my regards to that greatest person, Mr. Dr. Frederick Banting. He is the man behind discovery of insulin. He, along with his friend Banting and Best, Frederick Banting and Best, discovered insulin. The initial approach was from the Frederick Banting, and his birthday is 14 November. That's why the day is considered as celebration of World Diabetes Day. Is usually proposal from the International Diabetes Federation. Later on, WHO, the another giant organization for health, World Health Organization, put their hand together, and they usually celebrates the day as World Diabetes Day. And after discovery of insulin, the entire concept, pathophysiology, treatment guideline, everything changed, and it was like a gift from God's side for the type 1 diabetes mellitus, because type 1 diabetes is completely devoid of your beta cells, and if you don't supply insulin from any source, they will die. So it's a gift from God's side, and I think Dr. Frederick Banting was a messenger of God in that sense. So before I proceed to the next slides, I would like to convey my deep respects and regards to that great scientist. Next slide, please. Everywhere you'll see so many seminars, so many banners regarding diabetes or campaign of diabetes. There will be blue circle will be there. So a curiosity will develop in your mind that why this blue circle? This blue circle is a symbol of uh, unity for diabetes campaign. It's a symbol of positive symbol of cultures. The circle symbolizes life and health. Why blue? Particularly, so many colors. 7 colors is there. Why blue has been chosen? Because the color blue reflects the sky that unites all nations, and the border of the circle represents the color of the sky and the flag of United Nations. The blue circle signifies the unity of global diabetes community in response to diabetes epidemic that is considered as diabetic pandemic. Next slide, please. Now we'll be talking about the basic of diabetes. Diabetes, what do you mean by diabetes? How you can diagnose diabetes? What is the problem statement? What is the different, um, sign symptoms of diabetes? What is the complications of diabetes, and some parts of treatment? So one by one, we'll be discussing about the basic thing of diabetes. To start with, definition. Diabetes is a complex metabolic disorders of multiple etiology characterized by chronic hyperglycemia. There is tremendous rise of blood sugar level in your blood with disturbances of carbohydrate, fat, and protein metabolism. Remember again, it's not about the imbalance of carbohydrate metabolism. It is a disturbance of three proximate principle, that is your carbohydrate, fat, and protein metabolism, resulting from defects of insulin secretion, or it might be due to insulin inaction, defects in insulin action, or it might be due to both. Next slide, please. So this is the standard, diagnostic criteria laid by World Health Organization. Diagnostic criteria changes from organization to organization, country to country, region to region, and as a standard protocol, we have to stick with a single organization, and WHO is usually accepted by all kind of people, all kind of doctors, all kind of paramedical staffs, paramedical professionals, medical professionals, etc., etc. So what WHO state that if uh, fasting blood sugar level is more than equals to 126, or postprandial blood sugar level is more than equals to 200 milligram per dl, or HbA1c is more than equals to 6.5%, or a random blood sugar level cross more than equals to 200 milligram per dl, and the patient has some signs and symptoms of diabetes, is usually diagnosed at diabetes. Next slide, please. Now let's see the problem. Why we are considering and celebrating or observing this kind of World Diabetes Day? Because the problem is huge, and only only few part of the entire problem is usually seen by us. That's why it is called as iceberg disease. In community medicine, in the initial chapters, there is a problem is there, iceberg phenomenon. It usually comes as a short note in almost each and every year. So some disease you'll have iceberg phenomenon. What do you mean by iceberg phenomenon? Because the problem is huge, but only few part of that problem is seen, and very few disease have no iceberg phenomenon, like rabies, tetanus, etc., etc. Maximum disease has iceberg phenomenon. Only some part of the entire problem is usually seen. So many people suffering from diabetes will not be diagnosed or is reluctant to go to nearby hospital facilities, and very few of them will consult doctor or nearby health facility. They will be diagnosed as diabetes, and rest of people will suffer from the disease and will die, and patient and patient party will not know why the patient has died or what is the reason behind his death. So it's an iceberg disease. Global prevalence in 2019 was 57 crore people were suffering from diabetes. In percentage, if you see, that was 9.3%, and it rose to 10.2% by, it is expected to rose to 10 more than 10% by the year 2030, and it can exceed 11% by the year 2045. So see, out of 10, one people is suffering from diabetes. So it is evident that if the proportion of diabetes is such, so complication will be diabetes will be more or less same. The complication, microvascular complication even starts before the over diabetes. So complication of diabetes will also have the same type of prevalence, even more, right? So prevalence, worldwide prevalence of diabetes was usually in the urban side and less in the rural side, and prevalence is higher in the high income if you compare with the low income countries. So the high income countries is usually goes for, they have enough money to spend in their different activities, but diabetes is not that much prevalent in the rural areas.
So we can start again now.
Okay, no problem. So to continue with, next slide, please. If we think about the situation in our country, unfortunately, our country stands second in the total, diabetes count prevalence. And if this type of increment of diabetes patient each year, if continues, we will achieve, unfortunately, we will achieve the first spot very soon, maybe by 2025 or even faster, sooner or later. So just 2 to 3 years ago, whenever I was taking this type of seminars, I usually used to say that 69 million people is suffering from such and such disease, diabetes. And today I am seeing this type of slide, 2019 data. I'm very surprised that this data has been changed to 77 million people is suffering from diabetes in our country. That is almost 8 crores people suffering from diabetes out of 120 crore population, 120, 130 crore population. So out of the 12, one is suffering from diabetes in our country. And it is clearly, all over world, urban people is suffering from diabetes more if you compare this, because, urban people means there is lots of amenities, lots of recreation, lots of fast food, etc. Is there. If you consider Durgapur along with Laudua, you will see that all kind of fast food centers are more crowded in Durgapur, Asansol city. You can experience you can experience it, because you will see a Domino's pizza center in Kolkata, in Asansol, in Durgapur, but you will not see that kind of center in Laudua or Katabiya. Okay, so and people of rural people is more engaged in their physical activity, so more calorie burn is for the rural peoples if we compare with the urban people. So definitely there will be much more prevalence of urban people suffering from diabetes if we compare with the rural peoples. And I guess I'm very fearful that number will rise more and more if a very um, very appropriate step is taken to cope to tackle this global pandemic. Next slide, please. Now we'll talk about the risk factors. uh, you know some risk factors you can modify, and some risk factor is there for your patient. The risk factor you can't modify, like age you can't modify. Age, ethnicity, family history, genetic factors you can't modify. But there are certain factors you can modify, like improper diet or imbalanced diet, uh, weight, their lifestyle, physical activity. These are the some risk factors you can easily modify. uh, Next slide, please. And you have different kind of risk assessment codes. There is in the slide one risk assessment score is there. Apart from this, there is several risk assessment score is there. You'll be able to find out in over internet and over standard textbook. Now coming to the classification of diabetes, almost all diabetes will be type 2. If you make a pie diagram, 90 to 95% of the overall diabetes will be type 2 diabetes. 3 to 5% will be type 1. GDM is different kind of category. Gestational diabetes mellitus is different type of category, and very less proportion of people will be suffering from of other type of diabetes. Less than one, I guess it is less than 1%. Among this, type 1 is autoimmune diabetes. There is autoimmune destruction of the beta cells. Beta cells is present in the islet cells of Langerhans in the pancreas. Your own body against works against your own body. There is autoimmune destruction of the beta cells in the initial few years of your life. It starts usually at 7, 8, 9 years, and the process is complete within 6 months, 7 months. And after just matter of few months, the patient will have weight reduction, will have developed a classical triad, polyuria, polydipsia, polyphagia, and must seek consultation to nearby physicians for survival, and the patient must be on insulin for survival. And type 2, maximum means lion's share of the people, that is 9 to 9%, means almost all patient attending in Kilo will be suffering from type 2 diabetes mellitus, and very few, very rare patient will found suffering from type 1. So type 2 diabetes is a different kind of etiology is there. Insulin resistance plays a more definite role, and later on, due to gradual loss of beta cells, due to gradual loss of beta cells, in some stage of life, like in the year of 60s, 70s, it will behave like a type 1 diabetes. There'll be almost very little amount of beta cells will be left at that point of time. But until unless that time, the type 2 diabetes, uh, insulin resistance is the main culprit. GDM is different entity. It's beyond scope of this, educational activity. It will take several series of lectures to complete GDM, and other types of diabetes, it's beyond scope of this, educational activity. Next slide, please. Next slide, please. Type 3 DM is some reasons that is not considered type 1 or type 2 or GDM, that is called as type 3 DM. Genetic damage to beta cells, genetic damage to insulin secretion, type C. Ill or destroyed pancreas, type 3D. Hormonal distortions, type 3E. Chemical or medicine induced diabetes, type EE. Chemicals, type EF. Infections like Coxsackie, infection induced diabetes. 3G, abnormal forms of type 1 diabetes. You'll found many patients that is actually type 2, but it's presents like a type 2 in initial few years, later on converts into type 1. Usually we say that 1.5 type of diabetes, or LADA type diabetes. And type 3H, that is other diabetes related genetic syndromes, that is usually considered as type 3. All the spectrum is considered as type 3 diabetes mellitus. Next slide, please. Gestational diabetes mellitus is a complete different entity. It will be not matched with type 1 or type 2. It acts like a type 2. The some hormonal changes and physiological changes in the pregnant woman, diabetes develops from the you know uh, second trimester onwards. That is considered, and if the uh, diagnostic criteria fits, then you can say GDM. But uh, in the initial few weeks of gestation, I suppose that is actually type 2. And in that case, we'll say that pre-gestational diabetes mellitus. So next slide, please. And so many complication of gestational diabetes mellitus is there, and I think it is a different entry. It should be spoken in the different situation. Now, symptoms. Type 1 produces symptoms to great extent. Your patient will must have polyuria, polydipsia, polyphagia, weight loss, because there is almost all beta gone. So your body is in the state of absolute insulin deficiency. So there will be tremendous rise of blood sugar level in your blood. Tremendous rise of osmolarity will be increased, and osmotic diuresis will be polyuria, and our body can sense that my fluid is going down. So that's why your brain cells can recognize, the sensor system is there. We can sense, that's why the polydipsia, and there is lots or abundance of blood glucose level in your blood, but those glucose is not being utilized, so your satiety center is not fulfilled. So that's why polyphagia. Your body is asking more food, okay, but those things is not being utilized, and your muscle senses that uh, it's my duty to break down myself. I'm speaking is very easy language. My muscles is saying that it's my duty to supply blood glucose to my body. So the muscle breakdown is there. That's why so many weight loss. Fat cell also gets breakdown. Weight loss is there. So classicals, the polyuria, polydipsia, polyphagia we'll see in a case of type 1. And type 2, maximum of type 2 diabetes mellitus patient will not produce a single symptom. 60 to 70% of type 2 diabetes mellitus patient will not produce any symptom. And which diabetes occurs in the much more prevalent. Which diabetes is more prevalent? Type 2. 9 to 95% patient diabetes patient is type 2, and among those patients 60 to 70% will not produce any symptom. So it will cause inner damage, those macro and microvascular complications. After certain years, your physician will diagnose that, sir, you are suffering from some stage of kidney disease, diabetic kidney disorders, or sir, your vision will be irreversible, gone into an irreversible stage. That's why this term has been coined, silent killer. This term has been coined, silent killer. Diabetes is also considered as silent killer. It kills, but silently. Next slide, please. So apart from those symptomless, very few type 2 diabetes mellitus patient will, will complain about lethargy, weakness, delayed wound healing, recurrent infection, those type of, vague type of, that is not definite for any, any disease. So many patients will complain like such. Now, if you think about the complications, we can classify complication into two broad categories. One is acute and one is chronic. Acute complications, diabetic ketoacidosis, hyperglycemic hyperosmolar state, hypoglycemia, and chronic complications can be divided into two groups: microvascular complication and macrovascular complication. Some complication that involves your microvasculature and some complication that involves your macrovasculatures, means your broad arteries. Microvascular complications, it involves your eyes, diabetic retinopathy that can cause irreversible, vision loss. Kidney, it can involve your kidney and can create diabetic nephropathy, and it can involve your nerves causing diabetic neuropathy. And among the macrovascular complication, it can involve your brain, stroke, it can involve your heart, cardiovascular disease, and your extremities, PAD, peripheral arterial disease, narrowing of the arteries, blood vessels over a period of years of suffering from diabetes. And if any step is not taken in the appropriate time, amputation might be there. Chances of amputation increases. Next slide, please. Now coming to the management part, we'll talk into two parts. One is non-pharmacological treatment, that is the most important management of diabetes, and another is pharmacological therapies. Usually as a physician, many of us usually forgets to talk to our patient regarding this part. If you prescribe lots of medicine and if you don't take care about this non-pharmacological management, there is no use of prescribing lots and lots of medicine. Because if a patient is, non-compliant about his diet, his lifestyle, his oral hygiene, his food care, there is no point of prescribing insulin or different kind of OADs to that patient. Because depending upon the blood sugar level, you will calculate a dose, you will prescribe your patient. But if your patient don't know about the diet pattern, definitely his blood sugar level will be very much fluctuating. In some day, patient will complain about hypoglycemia, and in another day, the patient will come to clinic with more than 500 milligram per dl of level of blood sugar level. So prior to pharmacotherapy, you have to give more emphasis, more education about this non-pharmacological treatment. And in my opinion, this non-pharmacological treatment has more definite role if you compare with those pharmacological therapy. What things you'll consider in non-pharmacological treatment? First of all, diet change. You will prescribe a diet that is considered balanced diet. Total calorie requirement you have to calculate. It depends upon different formula. I have a very shortcut formula that if your weight is ideal, take your weight, multiply with his 30, that comes to be your calorie requirement per day. If my weight is 100 kg, not 100 is not ideal. If my weight is 60 kg, and if my BMI is within normal range, 18.5 to 22.99, so my daily calorie requirement will be 60 into 30. 1800 calorie. If my weight is in the higher side, if I am overweight or obesity 1 2 3, so I have to reduce my calorie intake by 10 kilocalorie. So if my weight is 60 kg and I am in the overweight zone, my daily calorie requirement will be 60 into 20, that is 1200 kilocalorie. If my weight is less, my weight is 60 kg but my BMI is 17.5 because my height is that high, somehow my BMI is less, 17 point something, so I have to take more calorie. So ideally my weight is 60 kg, have to be multiplied by 40, so I have to take 2400 calorie. Again it depends upon your physical activity and so many factors. It's a rough formula. Again it depends, plus minus 2 or 300 calorie, depends upon your physical activity, right? So you have to change your diet pattern. So you know how much calorie you have to take, and you take carbohydrate 50 to 65% of the total required calorie, 50 to 60%, 55 to 60%, and 15 to 20% of total required calories should come from protein and rest from fat. And saturated fat should not cross 10% of the entire calorie requirement. Ask your patient to take more and more fruits, more whole grain cereals, more food that contains dietary fiber. Ask your patient to go for food care, regular food care, maintenance of oral hygiene, increase physical activity. Those having no complications of brisk walking, they should be go for a walk at least 30 minutes, 5 days in a week, or in short 150 minutes in a week. Ask them to take medicine as per prescribed, as per doctor's consultation, as per your advice, and to check blood sugar level at periodic interval. And they should not never miss doctor's appointment or healthcare professional's appointment. So this is the things, non-pharmacological treatment. Your patient should be educated more about this. Next slide, please. Pharmacological treatment, insulin is there. Your Dr. Frederick Banting discovered insulin along with his colleague Best, and there is a professor of was a professor of both of them. He helped him. Ultimately, Frederick, Banting and Best got Nobel Prize. So insulin is a definite management of diabetes, but apart from insulin, in many cases, you'll be able to prescribe oral anti-diabetic medicines. And it depends which patient you will go to, will prescribe insulin, and for which patient you will go for OADs. Type 1 diabetes, if your patient have type 1 diabetes, they have no choice because they have no insulin. There is no, their beta cells has been lost, so they must be put on insulin for survival. For type 2 diabetes mellitus patient, if your patient has advanced disease, means patient takes OAD for a long years, 20 years, 20 years, 30 years, it is expected that his beta cell reserve has gone. So at that stage, if you straightforward put your patient into insulin. But for the initial few years, where your patient has evidence of beta cells, but somehow the patient have insulin resistance, for those you can prescribe oral anti-diabetic medicines. Insulin, to start with insulin, there is different type of insulin. Some insulin acts very short, and some insulin, if you push, it will act for a long time. And some insulin is mixed with short-acting insulin as well as long-acting insulin or intermediate-acting insulin. The short-acting insulin is insulin aspart, insulin glucose, insulin lispro. Regular insulin is considered as short-acting insulin. And long-acting insulin is insulin deglutide, insulin detamir, insulin glargine, and NPH insulin is considered as intermediate acting insulin. It's not short acting, not long acting, it is in between. And in many insulin is comes is a fixed dose combination some 20 or 25 or 30% considered is regular or short acting insulin, and 75 or 70% is there as a long acting insulin or in phase insulin. Next slide, please. Now, anti-diabetic drug, so many drug is there of so many groups: bigonides, alpha glucosidase inhibitors, dipeptidyl, you know, peptidase inhibitor, DP4 inhibitors, insulin secretagogues, sulfonylureas, insulin secretagogues, non-sulfonylureas, sodium glucose transporter 2 inhibitors, thiazolidine ingredients. So many anti-diabetic medicines, but from this discussion, it is my request to remember metformin, because metformin is the king of all kings. I usually use this term while taking any class about diabetes. You can forget everything, but you should not forget metformin, because metformin has so many advantage over the other molecules. Other molecules have also different kind of advantage. They have their area of, yeah, each and every molecule has its own advantage and disadvantage. That is different thing. But metformin is metformin. It's the king. It's the king of all kings. You should remember the medicine from this today's discussion that Sir has told about a medicine called metformin. Metformin is very cheap, very suitable for our country people. India is not a rich country. It can be prescribed to rich. It can be prescribed to poor. It can be prescribed to the lean people. It can be prescribed to the obese people. It can be prescribed to the liver people, means people with liver problems, though in the reduced dose. It can be prescribed to the people with kidney dysfunction, but with reduced dose. In many cases, you will not be able to prescribe metformin in case of severe renal impairment. That is different issue. Until unless your patient has severe renal impairment, you can prescribe metformin up to the maximum dose in all instances. Except liver and kidney involvement, to that great instance, you can prescribe metformin in all instances. Metformin is safe. Metformin is safe even in pregnancy. Very, very few medicine is found that is safe in pregnancy. So if your patient is pregnant, has diabetes, has mild increment of the blood sugar level, straightforward you can opt for metformin. It's not that you have to prescribe insulin in all cases. And metformin reduces your weight, so it's a bliss. It's a gift to the obese people. And apart from diabetes, it is also used in many other disorders like PCOD, etc., etc. So metformin usually comes as a dose strength of 250 milligram it to 1 gram. This company produces in such strength, but you can prescribe in a much more dose. You can prescribe 2 grams per day. You can prescribe 3 grams per day if your patient can tolerate it. But the rest of the molecules, it will be very difficult to discuss all molecules in this entire. It will take entire day to talk about, but it will be my request to remember metformin is the drug of choice in case of type 2 diabetes mellitus. Anything you can start with without any fear, that is metformin. Rest of medicines you have to take precautions, like if you want to prescribe sulfonylurea, it can create hypoglycemia. If you by some mistake, if you keep your patient in the improper dose, inappropriate dose. Similarly, if you prescribe SGLT inhibitor, that can also create UTI in your patient. If you prescribe DP4 inhibitor, again it can create more kind of GI intolerance if you compare with metformin, or it can also create pancreatitis, life-threatening condition. But in case of metformin, this kind of think our think tank should be kept in the other side. So without involving our brain to great extent, we can easily prescribe metformin. Metformin is that kind of safe. Metformin is that kind of safe for your type 2 diabetes mellitus patient, as well as GDM, in so diabetes in pregnancy. Newer molecules is there also, cholesevelam, epalerestat, that are also considered as a medicine for peripheral neuropathy, also acts against diabetes. So many new molecules is there. Next slide, please. So algorithm, so you have diagnosed a diabetes mellitus patient by WHO standard, WHO criteria. You have stratified risk, and you have prescribed and modification of the risk factors. Those risk factors you can modify. Lifestyle modification to be reinforced and to be continued lifelong. Look for the complication and treat them. Glycemic control is a very first and foremost criteria for a diabetes patient. If immediately start insulin if your patient has type 1 diabetes, because it has no choice. If your patient has in the emergency DK, uh, or HSS, previously it was termed as HONC. If your patient has symptomatic hyperglycemia to great extent, like it crosses fasting blood sugar level crosses 300, PPG crosses 350, 400, means HbA1c is more than 10%, or patient has severe critical illness, in that cases the patient will not be able to consume OADs. If a patient is on the semi-conscious state, he will not be able to take medicines, oral medicines. So better to shift to insulin for those patients. And in many cases, in type 2 diabetes mellitus patient, and in certain cases of GDM, gestational diabetes, you have to choose the oral hypoglycemic agents, tablets. Next slide, please. So metformin, I know you'll be able to answer many questions. Metformin is the drug of choice for diabetes, type 2 diabetes mellitus, initiation of choice. No question on that particular. And if your patient's glycemic control is not achieved, you have to add on next, other molecules of medicine. Metformin plus DP4 inhibitor, metformin plus DP4 inhibitor, metformin plus DP4 inhibitor plus SGLT inhibitor, or metformin plus thiazolidine plus sulfonylurea, like this. So you have to choose those medicine. You can use 3 different categories of molecule and look for HbA1c achievement for 3 to 6 months. If your patient's HbA1c is not achieved, again you have to shift to insulin. Again you have to shift to insulin. Now which insulin, what insulin? Again, that is beyond the scope of this discussion. It will take another talk. So next slide, please. Insulin, it is not that easy to talk in this way, but I am making it very simple. If your blood sugar level fasting and ppg is both high, but difference between fasting and ppg is not that high, means normal fasting is less than 110 as per WHO, but as per IDF, International Diabetes Federation, it should be less than 100. So ideal fasting is 80 to 90 or 70 to 90, and ppg should be somewhere around 110 to 130. So normally difference between the two is usually 30 to 50. So if your patient has fasting blood sugar level as 250 and ppg is 300, you can opt for basal insulin only, because primarily the patient has the basal insulin secretory defect, the basal insulin secretory defect. But if your patient has fasting blood sugar hyperglycemia, as well as there is tremendous rise of postprandial hyperglycemia, means example 250 fasting and ppg is 550, for those patients only basal insulin will not be helpful. You have to put one basal insulin and one prandial insulin, short acting insulin, before each and every meal to holistically manage your patient's blood sugar level. The basal insulin will tackle the fasting rise of hyperglycemia, and the prandial insulin before each meal will tackle the postprandial rise of blood sugar level, and we will up titrate or down titrate the dose after 2 to 3 days. That is the standard protocol. Next slide, please. Dawn phenomenon, Somogyi effects, it's a complex phenomenon. It's beyond scope of discussion, but still, Somogyi effects you should consider. It's a insulin. It's usually seen with patient having or is on insulin. What happens? Uh, there is a certain down of blood sugar level at 4 to 5 a.m. and the patient will feel hypo at that time, but at the morning 7 to 8 a.m. there will be tremendous rise of blood sugar level. That is Somogyi effect. Significance, that is correction of the morning hyperglycemia is by reducing but not increasing the evening dose. That is the standard protocol. Because what we think, if you see that there is 287 milligram per dl of blood sugar level at fasting, what do you think? We have to increase the dose, but patient is complaining that I am not feeling easy and at the midnight or in the dawn, means, you know 4 or 5 a.m. So ask them to do blood sugar estimation by themselves at that point of time and report back to you. So it can be easily tackled. So if your patient say, no sir, my blood sugar level is somewhere around 6 to 70 at that point of time and it is increasing, then somoggy effect can be diagnosed. So in that case you have to reduce the dose, not increasing. The different kind of phenomenon is dawn phenomenon. There is a, you know some to due to cortisol growth hormone, some dip of the blood sugar level, and usually gradual rise of blood sugar level onwards. In that case, there is usually we increase the dose, and in sonography we decrease the dose. And it will take another class to describe dawn and sonography effects. It's a beyond uh, scope of this presentation. Thank you. Next slide, please. So thank you. If you have any questions, you can put, because some mechanical or technical error will be there. So if you have any questions, put first in the comment box or whatever it is. I'll try to answer almost all of questions from your side. Thank you.
Thank you, sir. So that was a really informative session, and obviously we all know something about diabetes, but now we have a clearer picture of it. So there are a few questions which the attendees have given us. So during the session in the live chat. So the first question is why the life expectancy of a diabetic person is reduced.
What?
Why the life expectancy of a diabetic person is reduced.
Why? Because of those complications, nothing else. But if with this modern amenities of treatment, if your glycemic control is very good, HbA1c is less than 7. For younger people, the HbA1c lies between 5.7 to 5.96 for a quite of years. Life expectancy remains safe. But if your patient does not, come or visit your physician, is in non-compliant about his medicines, his lifestyle, obviously life expectancy will be reduced because of those complications. The patient will gradually develop microvascular complications as well as macrovascular complications. Suddenly, patient might develop cardiac, coronary heart disease and will have a heart attack and might die, or patient might develop stroke, might die, or maybe remain in the morbid state. That is the reason.
Thank you,
That
sir.
is the reason.
Sir, thank you, sir. So the next question is why is the cutoff for diagnosis kept as 126 milligram per deciliter? It is a very accurate number.
That is the based upon different series of studies. That is, the diagnosis is based upon series of studies, and this cutoff 126 is uniform. WHO also accepts this. IDF also accepts this. American Diabetes Association also accepts. The main difference is the fasting blood sugar level, impaired fasting level. WHO says the impaired fasting is if your blood sugar level rise between 111 to 125. Whereas IDF and ADA says, in American Diabetes Association says, impaired fasting glucose means 101 to 125. That's the only difference. 126 is based upon a series of studies and usually considered and acceptable by all kind of giant organizations. That is why.
Thank you,
That
sir.
is why 126. That is why 200.
Yes, sir. So
It is based on.
yes, a student asked that she had heard about a particular test to decide whether the patient should be dependent on insulin for his lifetime or not. So,
No,
sir,
no.
is there any such?
There is no kind of test as of now. Type 1, there is no option. In type 1, there is no option because your beta cell has been lost. There is complete destruction of your beta cells. There is no insulin. So your patient must be put on insulin for survival. They has no choice. Type 2, it depends. In our clinical practice, we get many patients, we'll straightforward ask them to take insulin. And 70 to 80% of our type 2 diabetes mellitus does not need any insulin. It actually depends, and depends upon several factors. How many years your patient suffering from diabetes, how many OADs your patient's taking over a long period of time, what is the insulin reserve of your patient. So many factors comes into play. So if in my clinical practice, if I'm a patient, I see his patient aged 60 years and he is taking OAD, 5 to 6 OAD. I don't know how they are taking those OADs for 25 years. I can easily assume that his beta cell reserve has gone down to that extent, almost similar to type 1. So there will be no point of increasing 1 or 2 more OADs to them. Unnecessary burden will be there. I'll convince him, I'll explain him, I'll take more time in discussing between him and me. We'll convince him, we'll agree that insulin will work better for him. But there is no such test. If there is test means you can do C-peptide estimation, that is indirect estimation. C-peptide usually attached with insulin. So if you and if it is detached, then only insulin works. Then only insulin works. So if you estimate C-peptide, you'll have a rough idea about your insulin reserve. That's all. But it is not that it is a it's a definite criteria of putting someone into insulin. It is not.
Yes, sir. Actually, sir, the 40 minutes time limit is over. So let's create a new meeting and continue the questions there.
Okay.
Yeah, thank you, sir. So I'll just get back to you in a minute.
Okay.
Yes, sir.
So you're back.
Yes, sir. Yes, so let's renew with our questions.
Okay, you are taking few questions more. Okay, tell me
Yes,
the
sir.
questions. I'll try to answer them.
Yes, sir. So, which is more dangerous, hyperglycemic or hypoglycemia?
Both are dangerous in their sense. Hypoglycemia means your blood sugar levels is below 70. If your age is in the younger side, you'll be able to cope hypoglycemia to some extent, 60, 55. But if your blood sugar levels comes below 40, there will be definite chance of coma. You must be provided some IV glucose for survival. And hyperglycemic, the patient 200, 250, okay, it will, kill you silently. But if your hyperglycemia level goes beyond that, means 300, 400, it may go into decay or HSS. In that kind, a patient might be put on IV insulin, and dehydration correction is must for them. So both are dangerous in true sense. Only hyperglycemia, if you compare only hyperglycemia with hypoglycemia will be more dangerous.
Okay, sir. Uh, so, why polyuria, polyphagia, or diabetic ketoacidosis does not occur in type 2 diabetes mellitus, as there is also increase in blood sugar?
Because pathophysiology or etiology of type 2, ketoacidosis also occurs in type 2. There is a misconception, but the extent of ketoacidosis will be more in case of type 1 if you compare the type 2. Type 2 etiology is different. In type 1, there is autoimmune destruction of the beta cells. There is absolute deficiency of insulin in your body. In type 2, insulin production is there, but there is an invisible barrier. That's why insulin is unable to take action, and that is called insulin resistance. That is the basic difference between etiology of type 1 and type 2. And that's why the classical triad of polyuria, polyphasia, polydipsia is not there in case of type 2 diabetes mellitus, because insulin is there. Insulin is able to take his actions, but in lesser extent. But in type 1, there is no questions of having insulin, because there is a the production cell of insulin, that is a beta cell, is lost. That is the basic difference.
Okay, sir. Uh, are the causes for diabetic ketoacidosis different from that of diabetes mellitus and diabetes insipidus?
What?
So, are the causes for diabetic ketoacidosis different from that of diabetes mellitus and diabetes insipidus?
I can't get you, because diabetes insipidus is different entity. It is nowhere related to diabetes. Because polyuria also occurs in the diabetes insipidus, and polyuria also occurs in the type 1 diabetes, or later in few years of type 2 diabetes. But diabetes insipidus is a totally different issue. It's a beyond scope of discussion of this today's class. Means discussion. It's an entire topic. It's dependent some antidiuretic. It's dependent upon the antidiuretic hormone imbalance of those things.
Yes, sir. So, why do some patients become resistant to metformin over time?
No, it is not a antimicrobial that will be resistant. Metformin will work for sure, but gradually there will be some loss of beta cells from your body in case of type 2 diabetes. Gradually,
Yes, sir.
in day-to-day manner, there will be loss of some beta cells.
Yes, sir.
And metformin has its own power. Metformin 2 gram will work like a metformin 2 gram. It will not work like a metformin 4 gram. So if your patient's blood sugar level is rising over a period of years, you have to switch to metformin or combine metformin with other molecules. Metformin alone will not be able to maintain the blood sugar level for each and every year, because there will be loss. It is inevitable that there will be loss of beta cells gradually from your body in case of type 2 diabetes mellitus. It's a natural history of the type 2 diabetes.
Yes, sir. So, why is the association of diabetes with immunosuppression?
Not only diabetes, each and every chronic debilitating condition reduces your immunity. Not only diabetes, each and every chronic debilitating conditions reduces your immunity. So many biochemical changes occurs in your body. That's the reason. not a definitive reason that only diabetes causes the immunosuppression and rest chronic illnesses does not cause. It is not. Okay.
Yes.
Any chronic illnesses, debilitating conditions causes there is suppression of immunity because of so many biochemical changes. So biochemical as well as hormonal changes. So many factors there.
Yes, sir. So do diabetes occur after the age of 60? If so, why?
What?
Does diabetes occur after the age of 60? And if so, why?
One reason I already told, there is gradual loss of beta cells.
Mm.
There is gradual loss of beta cells. There is a natural history of type 2 diabetes. That's why it usually occurs in the aged people. But nowadays it is also occurring in the
Will
middle aged.
diabetes
It also occurring in the middle aged, also called young age people. I have seen just yesterday. I have seen a 13-year-old type 2 diabetes mellitus. Can you imagine?
Oh my God.
But usually it's a disease of old age people. Usually, not always. And reason
Yes.
I clearly explained that is there is a gradual loss of beta cells occurs in type 2 diabetes or pre-diabetic patients
Hmm.
as per the natural history of diabetes.
Yes, sir. So will diabetes occur due to obesity?
Yeah, because I already told about risk factors of diabetes and obesity was there. Due
Yes,
to
sir.
more obesity, chances of development of insulin resistance is there. So, and that is a modifiable risk factor, so you can easily modify. You
Yes,
ask
sir.
your patient to go for a brisk walking, to stop those junk foods, to moderation of alcohol use. Those things you have to opt for to reduce his obesity.
Yes, sir.
Uh,
So does intermittent fasting reverse the diabetes mellitus?
what? Intermittent
It
fasting?
reverse diabetes mellitus.
It's very interesting because very few articles has been published over a few years that intermittent fasting and severe carbohydrate restriction diet can reverse diabetes mellitus. It is a debatable issue. It is a debatable issue. We can't, we can't prescribe those things in this platform. It's a
Yes,
debatable
sir.
issue.
Yes, sir. So can some patient diagnosed with diabetes feel the mild changes in the blood glucose through any symptom? Like, so,
No. Type 1 diabetes, the patient will come to your chamber immediately within 2 or 3 months because once his or her beta cell is gone, he will develop polypepsia, polyphasia. Right? I
yes, sir.
clearly explained why.
Hmm.
In case of type 2 diabetes, there is no such symptoms for 60 to 70% of patients. That's why it is termed as silent killer.
Yes, sir.
Patient will not produce any symptom for at least 60 to 70% patient. And out of 195 is your type 2 diabetes mellitus patient. So on those 95, 65 will not have any symptom. Only 30 means 30 to 35% of type 2 diabetes mellitus will have symptom, but that is very vague. It is not definite of any disease. Patient will complain about lethargy, recurrent infection. That is also common for other diseases also. That is
Yes, sir.
also common for in case of other disease also, not only
Yes.
diabetes.
Yes, sir.
So your patient will not be able to, and if your patient can recognize, he is very lucky, because if your patient can recognize that I might have diabetes, is very lucky, because he will obviously consult any doctor and doctor will test his blood sugar level, and if his doctor sees there is rise of blood sugar, he'll manage the patient
Yes, sir.
immediately. But it does not happen in our day-to-day practice because a type 2 diabetes mellitus is very reluctant about his health. Mm, HbA1c 16 point something, and patients say, "Sir, I don't have any symptom. Why you are saying to take medicines?" That is the problem. If your patient will produce any symptom, type 5, type 2, not type 1. Type 1 will produce symptom definitely
Yes, sir.
because it's a symptom producing diabetes.
Diet.
Type 2, if your patient produces symptoms and comes to your chamber, he is very lucky. It is my
Opinion.
realization. He is very lucky.
Yes. Yes, sir. So suppose someone is not, a patient is not feeling any changes with the treatment plan, and they are then resisting the treatment because they are not experiencing anything positive, and then they change their diet accordingly. So, sir, what do you think you should suggest then?
And that's why a a dedicated diabetes educator should be there for each and every diabetologist.
Yes,
They
sir.
will counsel your patient. They will increase morale of your patient, because no, it's a chronic disease. Once your patient has been diagnosed with diabetes, his morale will be automatically low.
Yes, sir.
What will happen with my life? What will be my future? I'll die. I'll not be able to take rasagullas. I'll not be able to take pizzas. So many dilemmas, so many queries will be in head roaming, will be roaming around. So that's why a dedicated diabetes educator or a doctor should spend more time at the very first instance. At the
Yes.
very first instance. So nothing to worry. You'll be able to take each and every food you want. You will be able to take each and every food you want, but in a limited amount. But in a limited amount. You'll be able to take alcohol, but there is more, should be moderation of alcohol use. You'll be able to take those fast foods, but very rarely, means once in a fortnight, or once in a month,
Yes, sir.
and rest 27 to 8 29 days, please follow my diet.
Yes,
So
sir.
in this way you can counsel the psychological part of a patient.
Yeah.
In
Yes,
this
sir.
way, you should tackle the psychological aspect of your patient, because
Yes, sir.
once the patient is diagnosed, he is definitely, he knows that it is not it's not a that kind of acute disease that is going to be finished within 7 days. It's not a fever. It's not a
Yes,
COVID
definitely,
that
sir.
will be all or none within 14 days, right?
Right, sir.
So psychological aspect, consideration should be there for each and every diabetologist, and that's why we recommend to keep a trained diabetologist in his or her chamber.
Right. So, what is the risk to the fetus or the baby if mother has gestational diabetes mellitus?
More blood sugar in the mother, definitely there will be more blood sugar in the baby. So baby's weight will be more. So macrosomic baby will be there. Chances of operative means cesarean section will be chances will be more. And in many cases there is loss of pregnancy.
Yes, sir. So, if is constant blood sugar monitoring necessary for type 1 diabetes mellitus?
Yeah, yeah, because type 1 diabetes, the patient must be on insulin. In
Yes, sir.
type 1 diabetes, the patient must be on insulin. And improper dose of insulin can create more and more blood sugar fluctuation. Dose can create more and more
Yes, sir.
blood. Not only insulin. If the patient takes improper diet, the doctor has said to take 2 rotis out of 60 gram attas, and the patient is taking 2 rotis out of 200 milligram or grams of attas. So your definitely your blood sugar,
Definitely, sir.
the carb, glycemic carb will be different.
Yes,
And
sir.
the doctor has advised to take 10 units of insulin as per that 60 gram of atta.
Yeah.
And the patient is taking 2 roti only, but out of 200 grams of atta. So definitely 10 units of insulin will not be able to tackle that rise of hyperglycemia.
Right, sir.
That's why both are important. Proper insulin, proper dosing of insulin, as well as that's why I've said it at the very beginning that non-pharmacological management is the main management of type 2 diabetes and type 1 diabetes, every diabetes.
Right. Yes, sir. So, how are the complications of hypoglycemia more fatal?
How?
How are the complications of hypoglycemia more fatal?
Hypoglycemia is more fatal. Coma?
Yes, sir.
Hypoglycemic coma is more fatal. It causes your permanent damage to your brain. It is that dreadful. Even if your reversal is there, it will cause a permanent damage to your brain cells. That's why we say we always train our patients about the symptoms of hypoglycemia. That if your patient develops sudden onset of dizziness, sudden onset of you know profuse sweating, sudden change of mood, sudden uneasiness, sudden weakness. So all kind of common symptoms of hypoglycemia. Please take 25 to 20 grams of glucose. If not available, you can take sugar. Sugar is easily available in each and every home.
Yes, sir.
And we usually utters the term take a rasagulla, and patient's face blushes in all kind of happiness. So that is very helpful now, because at 2 p.m. at midnight, who will take the calls and who will take the call? But if your patient is educated enough, you already put some education in your patient's mind that if this happens, take this. At least patient will get a new life for that particular night, right or not?
Yes, yes, sir. So, any significant role of genes in diabetes?
Yeah, definitely. Family history and genetic study, type 1 gene study is there, definite role
Yes,
is
sir.
there, and family history is there for type 2 diabetes mellitus, definite role is there. Genetic environment and family history, definite role is there. It's a proven fact. It's a widely accepted and proven fact. No reference is required.
Thank you, sir. Sir, those were the questions we've received in the live chat as of now.
Okay,
So,
thank you.
so we'll end our question answer sessions right now, and
Okay,
we'll be providing the feedback form in the live chat itself. If and the portal will be open till 6:15, and it won't be accepted after 6:15. So,
okay,
and your certificates will be issued according to the feedback form. Like those who will fill the feedback form, we'll issue the certificates for them only. So please fill the feedback form. And thank you so much, sir, for the informative session. It was a great honor to have you with us.
thank you, and I congratulate you all to arrange such programs. Very programs is being arranged from our students. My hearty congratulations, and this kind of educative seminars uh, will occur more and more in the near future. Thank you. Thank you.
Thank you,
God
sir.
bless you all.
Thank you so much, sir.